Good afternoon everyone and welcome, especially those watching on the screen. I'm Councillor Matthew Winnington, Cabinet Member for Health, Wellbeing and Social Care. This is my decision making meeting today. Just some housekeeping to start with. If the continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts. Assemble at Queen Victoria statue in front of the civic offices. In order to comply with the Portsmouth Cultural Trust fire marshal regulations, please remember to sign out when you leave the building after today's meeting. Okay, I'll just go around everyone first so people can introduce themselves. Start with you, Jane.
I'm Jane Tadino, a Local Democracy Officer.
I'm Marie Edwards, I'm Head of Regulated Services and Adult Social Care.
Alan Noble, Development Manager, Public Health.
Richard Webber, Finance Manager.
Thank you, and we have a couple of people in the gallery. If you can just shout out who you are. Excellent, thank you very much for coming today. As we've got no members of the public who are going to make deputations, I won't mention about the live web streaming apart from obviously it's on camera, but we haven't got anyone doing deputations, so I won't go through that point there. If we did have any public, they are obviously free to record this as well. Okay, so if we move on to the agenda, Jane, can I ask for apologies for absence?
Yes, we've had apologies from Councillors Heaney and Stubbs.
Thank you very much. Item 2 is declaration of members' interests. I don't have any declarations to declare. So move on to item 3, which is the Adult Social Care Older Persons Care Home Strategy. And over to you, Marie.
Thank you. So the purpose of the report today is to provide an update for members following the Cabinet decision making meeting in November 2018. For context, in order to provide a social care service that meets the needs of Portsmouth residents, meets the Council's statutory duty and manages the demand of increasing needs and costs, Adult Social Care have been developing a range of wild strategies covering changes in the way we work from 2018-19 to 2020-21. Implementing the Adult Social Care Strategy will achieve outcomes for residents and work towards financial balance by 2022. Our aim is that Adult Social Care in Portsmouth will be delivering services that have technology at the heart of the care and support that we offer across the city, working in a way that recognises the strengths that people have and have access to the networks and communities and draws on these to meet their needs. Working effectively and responsibly using a re-enablement approach centred around the needs of the customers is key. Delivering through a market-based on an individual services to people that meet their needs and help them achieve the outcomes they want to achieve and keep them safe. So this is very much around a strength-based approach. Deliver where it's appropriate through PCC residential services in one service area to enable quality and maximum effectiveness. So this strategy will enable adult social care to be financially stable and sustainable for the future. So these outcomes aligned to the priorities in the Blueprint for Health and Social Care Portsmouth, published in 2015. The main points were improve the range of services people can access to maintain their independence. Again, along the lines of the rehab services that we offer for the people of Portsmouth. Give people more control, choice and flexibility over the support that they receive. We want to do away with multiple assessments and bring services together in the community. Bring together services for children, adults and older people where there is a commonality of provision, including a family-centred approach. Create better resources and opportunities for vulnerable people and their carers. So the recommendations to the Cabinet in November 2018 was to build an extra care facility for people living with a dementia in Portsmouth and provisioning the site at Edinburgh House. The Cabinet members meeting on the 20th of November 2018 approved the implementation of a new staffing review, continuing to fund increased staffing in the short term while reducing the number of beds PCC would require in the future based on a demand analysis, which was discussed in full on the 20th of November 2018. The Cabinet members also requested that adult social care investigate gaps in provision in Portsmouth, which resulted in a recommendation that Edinburgh House be closed and the site be re-provisioned for the extra care housing for people with dementia. So an update on that is that Edinburgh House has closed. It ceased from we ceased taking people from November 2018. And with the process of the engagement with existing residents, relatives and staff and the wider stakeholders, it moved quicker than we anticipated, being led by residents and their families. They were offered opportunities to visit care homes if they wished to, and look at both the Portsmouth City Council provision but also private provision at the same time if they chose to. Adult social care had allowed until October 2019 to complete this process. However, as I just stated, that it moved a lot quicker because the families chose to move their loved ones quicker. As a consequence, we moved to a phase 1 consultation to have staff redeployed across the city. This coincided with the closure and there was no redundancies at the time. An application was made to remove the location from Portsmouth City Council's registration with the Care Quality Commission as part of the statutory process when provision of services changes. The building is now boarded up and a demolition programme is in place, estimated to be completed December of this year. During this time, engagement between project management and the service will enable the extra care facility to be designed and the build to be tendered. So that process is currently going on. So communication and engagement with existing residents and relatives and staff at Hilsey Lodge continued throughout the closure of Edinburgh House. And based on the analysis and the resources required, the Portsmouth Cabinet members' decision on the 20th of November was Hilsey was to be closed, enabling the site again to be repurposed. Following that decision in 2018, the closure of Hilsey Lodge, the moving of residents happened a lot quicker than anticipated, as it did with Edinburgh, and that was again led by relatives and service users. Placements were identified by the residents and families, and we had family members deciding to move sooner than the anticipated closure, which was going to be October 2020. As a result of this, the last resident left Hilsey Lodge on the 23rd of September. All staff have been redeployed, with staff deployed across the city in different provisions. So future options for Hilsey Lodge site need to be explored. However, the site will be repurposed to provide for gaps in provision in the city, likely to be extra care housing, supported living or social housing, but it's still in discussion.
Thank you for that comprehensive report, Marie. Just a couple of questions. Just on the situation with you said about the people in Hilsey Lodge in particular moving out earlier than expected. Have they? Can you just confirm that everyone who was in there, and actually in Edinburgh House as well, found that there was space within provision in the city, existing care home provision in the city for them to go into?
Yes, that's correct. So everyone, it was interesting in the consultations and the discussions with families that I led, that I would say, I think there was one out of both Edinburgh and Hilsey where they went to a private home because they wanted to live near their family members. Everyone else wanted to be moved to a Portsmouth City Council run home, and we were able to do that, which was really good news.
Thank you. And Richard, just a question for you on the finance side. In paragraph 2.2, where we're talking about the engagement between project management and the service to look at the obviously reprovisioning of Edinburgh House, can you just give us an update on how that works in terms of finance and etc. Press your button, please.
The proposal to repurpose the Edinburgh House site was included in the capital programme in February this year. Work is now underway, as Marie's highlighted, to start with the demolition process. The design work is underway led by the relevant housing team, and we'll be moving on to the tender stage as soon as the designs are completed. But obviously the designs we're looking at are going to be specific for the clients with dementia needs.
Thank you very much. And I'd just like to put on record about how I'm really pleased that this has been family and resident led in terms of moving on. I think there's this gives us, and the fact that we were able to absorb within our existing capacity within dementia care to care for to have these people moved in, and I think that this does give us a real opportunity now, obviously with the dementia extra care at Edinburgh House that we're going to be building, but also that whatever happens, there will be, obviously we've talked about physical disability extra care, which will be somewhere in the city. Whether that's on the Hilsey Lodge site or not is, as you said, Marie, up for discussion. But certainly that will be going ahead. But the most important thing is that Hilsey Lodge site will be used for either extra care, supported living or social housing, which is obviously within the provision we need in the city. So in conclusion, therefore, I am happy to accept the recommendation 2.1. It is recommended that the Cabinet member notes the progress against the decisions taken in November 2018 to provide good quality sustainable accommodation for adult social care in Portsmouth. So thank you very much. Marie, you are very welcome to stay if you need to anymore, but I do understand if you want to skedaddle. Okay, so if we move on to item number 4, so Alan is presenting this. It's the annual performance report for the Adult Substance Misuse Service.
Okay, so the purpose of this report is to update the Cabinet member and other members on the performance of the Adult Substance Misuse Service during last financial year, and the recommendation is that you note the contents of the report. We've been in a contract with our lead provider, Society of St James, since 2016, and they deliver the bulk of our substance misuse provision in the city, although they do subcontract some of the medical elements of provision to Solent NHS Trust. That's the bit where there's doctors and nurses involved. So the total value of the contract last year was just over 2.5 million. And for that money we get a very extensive level of service provision that includes, for example, harm reduction work like needle exchange, which prevents bloodborne viruses, outreach work with homeless, support workers that help to manage people through their treatment journeys, the doctors and nurses that provide substitute medication and alternatives to, for example, heroin, and a range of therapeutic groups, access to detoxification and residential rehab, as well as community residential rehab groups, and work with prisons, the criminal justice system, and liaison with hospitals for people accessing or have been hospitalised. So it's a very broad range of provision that's delivered. The service has been through a number of changes over the last year, and previously I've brought a report on the Vanguard systems thinking work and how that's changed the way that the service works. And that's led to an increase in the number of service users that are now accessing the treatment system. So we have around 140 additional service users compared to the previous year. And that increase has been for different substances, so alcohol and opiate users, particularly, as well as non-opiate users. That may well be crack cocaine, people that use just that, or cocaine. So that's really positive that more people are accessing and that the service is able to work with more people. In terms of successful completions, we've seen an increase in successful completions for all of the substances apart from opiate users. So we're potentially seeing less people leaving. However, we are holding them in treatment, which in itself is a positive outcome, because treatment itself, there's lots of evidence that shows that it will keep people alive and it will reduce offending, so it's better for the community as well. One of the other measures that we look at is around representations, and we've seen we've had a slight increase in representations around opiate users. Again, that may be that we're being better at attracting people back once they've relapsed. But for the other areas, we've seen improvements in representations. So that means once people leave treatment, then for the other areas, other substances, they're not coming back in such great numbers. So that's positive. As part of the Vanguard work, the service introduced a couple of different measures, and I've included those in the report. One of them is around service user satisfaction, and the data that I've included show that generally there's a high level of satisfaction with the service amongst its service users, but part of the Vanguard process is learning from the areas where there isn't satisfaction and when something's gone wrong. And that links to another measure which is called failure demand, which is again part of the Vanguard methodology. And that is logging when you get a demand from a customer reporting that something hasn't gone right or happened as expected. And the service will log these failure demands. And the chart shows that there's been a reduction in failure demands over time. And typically, a failure demand that we've recorded is where substitute medication hasn't been provided, or there's something's gone wrong between the prescription being generated by the service and it getting to the pharmacy and the pharmacy providing that prescription. And as the Vanguard methodology is a process of continual learning and continual improvement, there's now been a Vanguard systems thinking process just looking at the prescribing process to improve that. In terms of harm reduction, we've seen an increase in the number of needles distributed, fairly significant increase, 8.3%, which it's difficult to say that it's necessarily an increase in the number of injecting drug users. It may be that there's less sharing of injecting equipment and more take-up, because also positively we've seen an increase in the number of bins returned, so that's where there's been a positive needle exchange, dirty needles for clean ones. So it may be that actually we're getting more uptake by the people in the city that are still using. And naloxone, we distributed 255 naloxone kits. Naloxone is a heroin antidote that can be injected into someone's leg if they are having an overdose, and it can bring someone around very, very quickly, quick enough for enough time to be able to call the ambulance and get the ambulance to respond and try to save someone's life. So in conclusion, despite very significant reductions in treatment funding since 2013, and around a 40% reduction actually, the service is holding up reasonably well now, and the Vanguard systems thinking process, where we've tried to reduce waste, improve efficiency and improve customer experience, has potentially borne fruit in that we're now working with more people.
Thank you very much, Alan. I think this is a really, really helpful report. Shows that the work that's been done within the substance misuse services has been really helpful, and I'd like to thank Society St James for all their hard work they've done, especially going through that systems thinking process, but also in terms of really taking it on board and making it work really well. I'm really encouraged to see the quite substantial, especially compared to 2017-18, if you look at the increase of people making use of the service, which I think really does goes to show that if you engage more, then you will get more out. And I've also done a quick calculation on the representation, so it's in 18-19 we're overall less than 10%, which is a a fantastic thing, and just makes me despair as why we don't treat a lot of crime as public health, because you probably get more of the outcomes like that rather than the ridiculously high reoffending rate that you get in crime, because they treat it as a punishment and it just doesn't work at all. That is to have no non-opiate representations at all, and the most you have in anything as an opiate with 5 is I think is a real testament to the work that's been done. The other thing that I was very struck by was the naloxone part. So for the benefit of people watching, in the report it says that naloxone has been used a number of times in our supported housing projects to prevent overdoses becoming deaths. Service users has also reported using the drug to save the lives of friends. And I think that is an absolute testament to how important it is to have a resource like that. And the fact it was there were 255 kits done a year, that could potentially be 255 people whose lives been saved just by that investment, and that is a significant investment by the council. But we really do believe that this kind of thing, having that as a harm reduction tool, really does make a difference, and especially as we do have a lot of vulnerable people in the city. So I really like to thank the work of the public health team who have worked with SSJ and obviously come to myself and the rest of the administration about that work. I don't think there's anything else on that, but I'm very happy to note the reports. And again, I'd just like to pass on my thanks and congratulations to the work of both your team within public health, Alan, and Society St James, who are contracted to do the work for us. Okay, so move on to agenda item 5. Which is the changes to data that Portsmouth provides to the National Drug Treatment. I think there's a word missing there. Monitoring system. Yes, sorry, that was a couple of missing words on the front page of the agenda there.
Okay.
So Alan, over to you again.
Okay, so in many ways this report is linked to the previous one, in that it is linked to the Vanguard systems thinking work that the team, the substance misuse team, have gone through. So we're seeking approval from yourself to reduce the amount of data that was provided to the substance misuse the National Drug Treatment Monitoring System. So it's effectively to reduce the data burden and the burden of bureaucracy, I guess, on the service, so that they can focus on what is important, which is their interaction and their engagement work with the service user. So the National Drug Treatment Monitoring System state that their data helps drug and alcohol treatment demonstrate the outcomes it achieves for people it treats, and in doing so aids accountability for the money that's invested in it. We provide measures that support the government in their decisions around drug treatment and their funding of drug treatment, and the data that's included things like the proportion of clients that successfully complete treatment, value for money, progress on measures such as housing, employment, health, quality of life, the number of children who could be affected by adult substance misuse, etc. And on the whole, this is data we will still provide. We're still going to provide data on a lot of the protected characteristics, which we're required to. But the context of this is that since 2013, the amount of funding that the substance misuse treatment system has had has reduced from around 4.7 million to around 3 million in total this year. Through recommissioning, proactive contract management, through the Vanguard systems thinking process, we've been able to maintain a functioning service. However, the data burden hasn't changed, and if anything over that period it's increased with more data fields, more data requirements. So the data burden is proportionately greater than it was for a more reduced service. And that's mirrored nationally, where there have been significant funding reductions in substance misuse across the board. So NDTMS, National Drug Treatment Monitoring System, does have mandatory data fields, but in itself it's not a mandated public health function to undertake the returns to NDTMS. So as I mentioned in the previous report, we've been through a systems thinking process. The aim of that was to improve the client experience, to remove what we call waste work, and to focus on helping our clients to make their life better. The Vanguard system thinking as a process has a clear principle, which is that we pull, not push. So clients pull on the service and what's of value to them, but we don't push things that don't add value, that are unnecessary or unwanted by the client. And potentially the NDTMS data burden is things that we're pushing on the client rather than what they're pulling on and what's of value to them. So we're suggesting that there's as well as some of the non-mandatory fields, the mandatory fields that we don't report are time since last paid employment and age first problem substance use. We're suggesting we don't do those because service users on the whole will have a problem with what in public health we call recall. They're not going to necessarily remember when they first started using a drug. So if we have for example, someone in their 30s presenting who's been using drugs since they're 17, 18, they're not going to remember exactly. And actually it probably doesn't change what we're going to do with that person, because the issues are live there and then and are not 12, 13, 14 years old. And often, so we don't think the data is necessarily reliable, and it doesn't add any value to the work that we're going to do with the individual. The final area is the severity of alcohol dependence questionnaire, which in itself is another 20 questions. And we feel that when someone's coming for their first assessment, we're trying to understand what's really important to them, their background, what they want from treatment, to then go into an additional 20 questionnaire in addition to all the other questions just adds to the burden. However, prior to someone going on a detox, an alcohol detox, we would of course undertake the questionnaire because it will determine the level of treatment that they need and the level of medication, etc. So it's also proposed that we do not use the do not submit and use the treatment outcome profile, and there's a copy provided as an appendix. This is an area that captures 27 different fields linked to substance misuse, injecting behaviour, crime, and health and social functioning. Again, this relies on self-reported responses by the service user, which has issues with reliability, and as I've said, recall is a problem. And people are asked, for example, on what did they drink on the last 28 days. So many people will struggle with trying to remember that, or how many times they may have used drugs in the last 28 days. Also, there's certain areas, such as the crime area, where people probably aren't honest. So again, it means that it's not reliable data. So during the Vanguard check process, the Vanguard work, we found that this was a push, not pull process. Service users didn't value it, and staff struggled with it, found it generated a lot of waste work where they're chasing people to complete something they don't really want to do. So we're suggesting that we don't no longer do this. Section 5.3, however, does highlight the benefits that the National Drug Treatment Monitoring System have said for TOP, and that it allows us to benchmark against other areas potentially. It can be used as a motivational tool with clients, and that NDTMS use this to make the case to national government for funding. Since the Vanguard process has been brought in, I've highlighted two measures in the previous report around service user satisfaction and failure demands, which allow us in real time to try and improve the service. And in addition to that, we effectively replace or seek to replace TOP with two other questions, which is around substance use. So we can show that we're having an impact on someone's substance use, and that the substance use is going down, or they're abstinent, i.e. they're not using any drugs or alcohol. But this measure, rather than being based on what the service user says, is based on what the worker says, based on interactions with the service user, but also urine tests that we undertake, so that it's based on something a bit more factual than what the service user self-reports. The second measure is quality of life, and we've just recently introduced the measure, which is and it is linked to so our Vanguard purpose of the service was to help people make their life better. So we've linked it to that. So we'll ask them, is the work that we're doing helping you to make your life better? But that service user will then be able to say yes, no. It's quite meaningful in that respect that if they say it's the same or worse, that the worker then has an in into understanding a bit more what's going on for that person and what we can do to try and make their life better. So in conclusion, the national data requirements have not reduced and place a disproportionate burden on the services who are seeking to maximise client engagement rather than pushing data and data collection onto them. And that we would like approval to not undertake those additional the fields that we feel do not add value, and the TOP, which is replaced by two other measures which we feel are better.
Thank you, Alan. What risks are there? I mean, other than what you said there, actually you sort of said about National Drug Treatment Monitoring System. You're saying that they need this data. What risk is there if we don't provide?
Through talking to NDTMS, they feel we won't be able to effectively benchmark ourselves against other areas and compare our performance of our treatment system to the performance of other areas through the TOP data effectively. The risk with that is that we could have a poor performing service and not know it from their perspective. In terms of risks to us, the only thing that has been reported to the Director of Public Health or mentioned to the Director of Public Health is if we have less data available to us when we bid for work or additional grant funding from Public Health England, we may struggle to make our case if we are lacking some of this data. However, on the whole, without this data, Portsmouth's been relatively successful in winning grant funding so I'm not sure how accurate that is. So at the moment, that's the only areas that NDTMS have not suggested to us that there would be any financial implications or other implications coming from Public Health England.
Thank you. So it seems to me like the data that they want is more for their benefit than ours, and for all that they say that we can't prove things as well, we're still managing to win bids even without that data. Okay, and you mentioned about the that it was creating waste work. So what, by not doing this, what advantage will that have in terms of the level of service we can provide?
Essentially, it frees up practitioner time. What we were finding, because it's a very high level of data burden, and there was a data system that we put in place that would flag up to the practitioners when their 3-month reviews were due. They would then be trying to track down the service user, trying to get them in for appointments. We would have missed appointments. We'd have very difficulties trying to encourage them in to do it. Yeah, a high level of DNAs for top reviews. Sorry, did not attend for top reviews. What by not doing it, essentially what it does is free up time to focus on doing the work that we are pulled on to do, rather than pushing things that service users don't want to do. And we found that the burden of top was quite significant. So it has, I can't quantify it, but it has freed up worker time, which may well be why we're also seeing more people, and the service is more accessible because we've moved from assessments 2 days a week to 5 days a week, drop-in assessments. So it's freed up that time and the capacity to be able to do that.
And one last thing, Alan. You said right at the beginning that the NDTMS is not mandatory, it's not a mandatory function. Can you explain why that is?
Public health has certain mandated functions, so the grant that comes from central government to Portsmouth City Council, there's certain elements of it which are mandated, and the government says the council must provide, and those elements include a comprehensive sexual health service, health checks, what they call the core offer, or advice and support to the clinical commissioning group. So those are examples. Substance misuse isn't actually a mandated function within that, and therefore the data requirements within substance misuse aren't mandated. So therefore we don't have to do it as part of the conditions of the substance misuse grant.
Thank you, Alan. So yeah, just to clarify there, the substance misuse, it is not a statutory function of a council to provide the substance misuse service. So the fact we do, which is absolutely right, is means that we then have a non-mandated, but they like to see it as mandated data that comes through. Thank you for that, Alan. On the basis of the report, and I thank you for that, and all the information in there, which does, I think, go to show the somewhat over the top and sometimes either not very clean or quite frankly completely pointless data gathering exercise, which the NDTMS does do, plus the fact that it does not appear to have any impact on our ability to be successful in bids, nor does it, has there been any indication of it's going to not enable us to monitor ourselves how good our service is, and obviously from the feedback we've had from clients, which quite frankly is the most important thing, I am happy to accept the 2 recommendations, which are: the Cabinet member approves a reduction in specific treatment data collected and submitted to the NDTMS, and the Cabinet member approves the additional service improvement and outcome measures which have been developed as part of the Vanguard Systems Thinking intervention. So if we move on to item 6, back to you again, Alan. Funding for the refit project.
Okay, thank you. So the purpose of this report is to update you on the forthcoming ceasing of lottery funding for the refit project and to seek some funding to maintain a service, albeit reduced. The refit project is a partnership between our lead provider for substance misuse provision, the Society of St James, and Pompey in the Community. And it works with people who suffer from addiction to drugs and alcohol, and it provides daily diversionary leisure and sport activities alongside training, education and employment opportunities for these individuals, all of which can significantly improve people's physical, mental health, self-esteem, confidence, social interaction and motivation. I've listed some of the aims of the service within 3.1, and the model for refit is detailed in 3.2, which shows that the sports and activity engagement is used as a way of getting people to become active, to have social interaction, and then to start volunteering, developing some of their life skills, then potentially moving on into other community groups and undertaking learning activities. So the project is more than just providing badminton on a Tuesday. It encourages people that attend to start volunteering as activity leads, getting coaching badges, undertaking health and social care NVQ work, to then maybe take on a work placement somewhere and then move on to get a job. And why that's really important for substance misuse is that for a lot of people who have been in drug or alcohol addiction for many years, their sole purpose is to acquire the substance for which they are addicted to, and their day revolves around acquiring that drug. And when they stop taking the drug and they're removed from their social groups and their networks, they often suffer from isolation, depression, and not knowing what to do with themselves. So why a project like this is really, really important, and why it underpins the rest of our treatment system, is that it helps people to stay clean and sober, and it helps them to interact with like-minded people with the aim of moving them on into becoming a more integrated part of our community. And without this type of work, people will have a much higher likelihood of relapse and going back into our treatment system and being one of those representations that come back in, and the whole process has to start all over again. So with the funding that we're requesting, although it won't maintain the project at its current level, it will save the project from closing, and it allows those partners, SSJ and Pompey in the Community, to continue to bid for other bits of money to help maintain or grow the service slightly. But without this money, effectively the project will fold.
Thank you, Alan. Richard, we've just got the so it'd be £29,000 for 2 years, and I think I'm right in thinking that at the end of that 2 years, the SSJ contract would be up for renewal. Is that correct? Yeah, and therefore, would there be a possibility then of looking, if there wasn't any lottery funding in the interim, that would could be combined within the contract as a whole?
Initially, as I've highlighted in the report under the finance comments section, we would either in the short term seek to identify funding from any underspend within the public health budgets. In the second year, we would seek to try and, in setting the budget for 2021, seek opportunities to try and find opportunity to include it within that funding. In both of the years, if that's not possible, then we would need to call on the Public Health Reserve. At this stage, we don't know yet what the public health funding allocation is for 2021. There was an indication in the recent spending review announcements, but until that grant is actually confirmed, we don't know what the level of funding looks like for that year, and we also don't know what it looks like after 2021 at the moment. So we would work with Alan and his team to seek to try and do what we can to support the project, identify funding opportunities where they arise. But at this stage, with all the uncertainty, I can't really answer your question.
Thank you. Yeah. So, but I think that would be the depending on obviously what the what that would look like in 2 years' time. Then that will be our opportunity to do that. Just on the Alan, so in 4.2, where we've got about the balance of 74 staffing hours would come from a review of staffing hours across the whole substance misuse contract. Would that mean that in addition to the post would be funding that SSJ and Pumping the Community would look to put some additional resource if they can find it within their existing provision?
Yes, that's correct. The balance, so 50% of the hours would come from Society of St James trying to rejig across their whole contract, the £2.5 million contract, and the very extensive provision they have to provide, but they would look to find the balance of the hours to make it sustainable for the 2 years, because you couldn't have one person delivering this on their own. So yes, it would come from the Society of St James.
Thank you. Yeah, and just on the refit project, I mean, thank you very much for putting their report from 17-18 in there. It's an excellent report, and having worked with people who have used refits myself, I do know how valuable it is, and as you say, it's an absolute godsend for people who have spent their waking hours looking for opportunities to get a hit of alcohol or drugs, or in some cases as well, those who have multiple addictions, gambling as well, to fill their hours with something else, something that they enjoy and they can have fun doing, but also can have some really positive outcomes in terms of their enjoying themselves and their general well-being, as well as you say, the ability to have qualifications. So I'm very pleased that to approve this, and it's a shame the lottery funding has ended, and I really do hope that bids for lottery funding or other funding in the future is forthcoming, so that this can have a sustainable future. But certainly from the public health point of view, I think we have to try and support this kind of thing as much as possible. Going right back to that report that we did earlier, our representation rates are very low, and this is one of the reasons why. So I'm entirely happy to accept both the recommendations, which is to approve a funding contribution towards the Pompey and the Community refit worker post of £29,000 per annum, a total of £58,000 for 2 years from the 1st November this year, and approve that in the first instance funding for this project would be identified from any underspend in the current financial year public health grants. In the following financial years, opportunities to fund this expenditure within the relevant year's budget would be sought. Should any funding shortfall be identified, then the funding from the Public Health Reserve can be utilised. And that's it. So thank you very much, everyone.